This is the DCH IV to PO conversion program pharmacy student review. You should have several packets that were given to you. The first one will be the DCH IV to PO conversion program policy and procedure. There will be a student responsibilities and other areas of clarification or confusion to help evaluate patients, Meditech functions, and also student quizzes and case studies. We're going to start with the policy first. The sections that will pertain to the student would be number 1, which is the purpose. These medications will be medical staff approved to be converted from IV to oral. They offer several different benefits to the patient for infectious disease-related issues to help remove the IV sooner. They also expedite the discharge process, and in some circumstances there are cost savings to the hospital. However, most of these drugs are now generic, so it's not that big of a cost savings, but it is still beneficial. Section 3 deals with a policy. Patients that are eligible for review will print from a computer system called Midas Care Management IV to PO work list. Your pharmacist that you're assigned to will provide you with the Midas work list, so you do not have to know anything about how to get into the Midas system. Students and pharmacists are responsible for carefully screening patients for any contraindications that would inhibit them from receiving medication safely through the oral, NG, PEG, or OG tube route. Pharmacy and Therapeutics Committee has approved all of these medications as equivalent oral formulations of the intravenous medications. The policy is broken down into 3 categories of medications or drug categories. The first one will be medications. Under that, we have Keppra, Prevacid, Reglan, Robaxin, Protonix, and Prevacid. Currently, we have a DCH therapeutic interchange in place for Prevacid, so the PPI of choice would be Protonix. All of these medications can be converted to the same PO dose as they were prescribed IV. There are some notes at the bottom of the screen that you'll want to pay attention to. Protonix doses typically utilized for GI bleeds are 80 milligrams, which can be given intermittently or by continuous infusion. These are not targeted via the Midas work list, so you should not see an 80 milligram dose of Protonix. However, keep in mind that some physicians will still use the 40 milligram dose to treat a GI bleed, so we have to carefully screen these patients. The criteria that patients must meet for the medications listed above to be converted from IV to oral is that the patient must be receiving a scheduled oral medication and or diet. So 2 points I want to emphasize. The oral medications need to be scheduled and not PRN. We want to make sure that they're receiving them and tolerating them on a regular basis. The patients can have an oral diet and no scheduled oral medications and still qualify. So this seems to be an area of confusion. Both criteria do not have to be met, but one or the other needs to be met for conversion. For the PPIs, we also want to make sure that the patient does not have a gastrointestinal bleed, because that would rule them out for safe conversion initially, and we'll go into this a little bit more in some of the clarification points. The next category of drugs covered in the IV to PO conversion program will be antibiotics. There are only 2 listed in antibiotics. It's linezolid and voriconazole, and again, they go to the same oral dose as prescribed IV. There are several more conversion criteria for these particular antibiotics. The first one is the same. They must be receiving scheduled oral meds and or a diet. Additionally, the patient has to have a decreased white cell count if it was initially elevated. Does not have to be within normal limits. It just has to be responding to the drug therapy that was prescribed. If the patient's white cell count is not trending down, you probably want to alert your pharmacist to that so that they can discuss alternative therapies with a physician. The patient should not have had a temperature spike greater than 102 degrees in the last 24 hours. And then finally, as part of the medical staff approval, the infectious disease physicians wanted to make sure that we did not convert any patients who were receiving therapy for one of the restricted infectious diseases. These are osteomyelitis, septic arthritis, meningitis, or endocarditis. And we will go into these a little bit further in just a moment. The final category is called automatic antibiotics. It's azithromycin, fluconazole, levaquin, and ciprofloxacin. We do have a therapeutic interchange in place for ciprofloxacin, so you will probably not see that. However, if we were to ever change that, it could be enrolled in the program. With the exception of Cipro, all of the antibiotics listed here will be converted from the same dose IV to PO. Now, the automatic antibiotic conversion criteria, you can see that the first criteria that says, due to the high oral bioavailability of these antibiotics, it is not necessary to review white cell count, temperature, or restricted infectious diseases. These antibiotics are approved by the medical staff for expedited or automatic conversion if they can tolerate oral ingestion. So really, the only criteria that the patient must meet is that they're receiving scheduled oral meds and or a diet. One special thing to note here is if the patient is receiving continuous tube feedings, the fluoroquinolones should not be converted due to the high likelihood of binding. The remainder of the items that are listed in the policy are procedural steps that will be carried out by the pharmacist. So you really don't have to, we won't go through any more of the policy at this time. You have some additional handouts that are areas of confusion a lot of times when students begin evaluating patients, so we wanted to go through some of those. And I have bullet points listed of these topics, and you can refer to your handouts for the details. Continuous tube feedings, we just talked about, is an exclusion for fluoroquinolones, but it does not exclude the patient for the entire admission. We just want to make sure that we will review them in a couple of days. More than likely, the patients will be converted from a tube feedings to an oral diet, and at that time we can schedule fluoroquinolones away from their mealtime. The next area is gastrointestinal bleeds. Again, this one is an exclusion criteria for acid suppression medications, but it does not exclude them from their entire admission. Once the patient becomes stable and they're receiving other oral medications and or a diet, then we can safely convert them at that time. Some of the other, there's another handout in your packet that talks about evaluation for a gastrointestinal bleed. If you have a patient that's on a PPI, you probably want to look at the progress notes and orders to see if the patient may be having any other orders that could be clues for a GI bleed. You might see things in the progress notes related to hematemesis, red vomitus, coffee ground material. You might also see orders for things like Hemocult, stool guaiac, those serial H&H. Those orders might clue you in to a possible GI bleed, and you can discuss the patient's condition with the nurse at that time. The next topic is gastrointestinal surgeries. This could be a small bowel resection to colostomy, and it will initially exclude them from conversion, but again, like GI bleeds, once they become more stable and are receiving oral meds and a diet, we could convert the target med from IV to PO. Evaluation of white cell count, we talked about this earlier. This does not affect the automatic antibiotics, but it does affect the antibiotic category, which is linezolid and voriconazole. As I previously stated, we need to evaluate their white cell count. We want to see that since the drug was started, that the white cell count is trending down. It doesn't have to be within normal limits, but we do want to see that it's decreasing. As I previously stated, if their white cell count is not responding after 48 hours of therapy, you probably want to alert your pharmacist. Most of the linezolid and voriconazole prescribing in the hospital is being monitored by our antimicrobial stewardship program, and the ASP pharmacist is probably monitoring these, and he will convert them to oral when they're appropriate. Most of the time they will be converted before they hit your list. So there's probably not going to be a lot of opportunities for you to have to evaluate these extra criteria for these two antibiotics. One other thing I want to point out is I mentioned that you would get your work list, the pharmacist would print it from Midas. These antibiotics, the medications can hit the list as soon as they're ordered. The antibiotics, however, do not appear on the list until the patient has received at least 48 hours of IV therapy. This is another criteria specified by the medical staff. Once they hit your list, they're eligible for conversion if they meet the other criteria. NPO status. Sometimes NPO status, if you see that written, it can be confusing. We have an NPO, which means the patient should not receive any meds or diet orally. We also have an NPO except meds. That means that the patient is not receiving an oral diet, but they can have oral medications. So don't be confused if you see NPO. You always need to double check the patient's medication profile and their diet orders. The last area for confusion is the restrictive infectious diseases. You have a handout for this. Definitions are listed there for osteomyelitis, septic arthritis, meningitis, and endocarditis. The thing to remember about these is that they usually require long-term therapy, 14 to 21 days. The patients typically do not stay in the hospital for that length of time, but their medications do continue as outpatient or home meds. Oftentimes, they will have home IV infusion therapy, and we have agreed not to convert these. And those, so like I said, if it is part of the restrictive infectious diseases, we will not convert those orders. We will leave that to the discretion of the physician. Now, if you've evaluated your patient and they are eligible for conversion, you will want to print the IV to PO conversion form from the DCH intranet. It is listed under the physician orders section. Here's a copy of the order form, and it states at the top it's the IV to PO conversion form. There's an inclusion section stating all of the criteria that we just discussed, and really the answers to these should be that they meet the criteria, or else you wouldn't be filling out the form. If you go on down, you can see that the medications are listed on the left-hand side. You would check the medication that the patient was on. If the same patient had multiple medications, you can check all of them on the same form. You will check the IV dose that they were prescribed, and then the IV dose the oral dose that they will be converted to. You want to indicate the dosing interval and the start date. You want to keep in mind if it is a once-a-day dose and the patient has already received their dose for the day you're evaluating them, you will not start until the following day. There are two signature lines at the bottom. Per medical staff approval is the line that the pharmacist will sign. You as a student could sign right above per medical staff approval, write your name, PharmD candidate and the year, and then they'll take it to the pharmacist. They will sign it and process it and place it on the chart. All right, the next handout you have in your packet is called Meditech Functions. There's a lot of topics that are covered at the beginning of that page, which talk about how to log into our computer system, which is Meditech, how to set up your password, and then get into the main menu. From there, you'll see different areas that you can go to. Process orders is the pharmacy menu. You can look at medication profiles there. But you can also look under option 200, which is PCI, patient care information, and that's what we're going to talk about here. Once you're in PCI, you want to use the left and right arrow keys and the up and down arrow keys to navigate the system. Once you log in, the two main areas you'll want to go to are current meds. Once you arrow to current meds, you will right arrow key in, and then you can look at all of their medications on their profile. You'll want to look for PO meds. If you find one, you want to make sure that it's scheduled. You can highlight that medication and then right arrow key in to that medication and look for a section called administered medications. This will let you know if the patient is actually receiving their medications on a regular basis. If it's a BID medication, there should be 2 dosing options per day. If for any reason these are not given, most of the time if they're given, it'll say yes. If they were not given, it'll say no or held and a reason why. This could indicate for some reason that the patient is not tolerating their meds. You may see held due to vomiting or held, for another reason. But that may give you, if the patient were having problems tolerating their meds, we don't want to convert additional medications to the oral route that would potentially hamper their improvement. Once you come back out to the main menu where you first saw current meds, you can scroll down to orders. This is where you'll find diet orders. You right arrow key in, go to diet, and review the diet ordered. It can be anything from a clear liquid diet, regular diet, full liquids, an ADA diet, or a cardiac diet. Things to keep in mind is that, we've already discussed NPO, but clear liquids also really don't meet the criteria for an oral diet. This is a transition period where they're trying to see if the patient can tolerate an oral diet. If they have progressed on to a full liquid or even a regular type diet, then that would be fine to make the conversion at that point. Full liquids are heavier things like cream soups and grits, so you know that the patient will be able to keep those down and progress on to a regular diet. So again, don't convert if they're on clear liquids. If they were just recently started on a clear liquid diet, you probably want to make note of that and just tell your pharmacist, and then they'll document that in the Midas system. Any conditions you see about the patient, especially if they were having, when you reviewed medications, if you saw nausea and vomiting, you might tell the pharmacist they're on scheduled oral meds, but they're having nausea and vomiting. They can enter this information into the Midas system, and the next day when they print your work list, those issues will still be on there, so you will not have to start over evaluating the patient from scratch. You will pick up and you'll go in and see if those have resolved or if they're getting worse and they have no scheduled oral meds and they have no diet orders now. And then that would be a true indication that you could not convert their target medication to PO. Some of the other categories that are in PCI that may help you: query responses by group. If you right arrow in, you can see bedside nurses notes. Right arrow key in again, you can see percent eaten. This is good for an oral diet, especially if they're just getting started on a new oral diet. You can also see things like gastric residuals. So if the patient is on a gastric tube feeding, if their gastric residuals are greater than 150 on up to 300, you can assume that they're not tolerating those very well, and you probably wouldn't want to convert them. Again, if you were evaluating a fluoroquinolone, gastric tube feedings would be a contraindication, but only for fluoroquinolones. Another category is assessment forms. If you right arrow key in, nurses conduct adult system assessments, and these are like shift assessments. So they're going to do them 3 times a day. If you right arrow key in again, you will come into that full document. You want to look at the last one documented, and then you can page down to the gastrointestinal section. That's the header of that section. And to see, there's several things there. There's a question for tolerating diet well. The nurse will answer yes or no. There's a section called NPO and a section on nausea, vomiting, diarrhea. All of these fields the nurse can answer yes or no, and it will be the most up-to-date information available to you. So those are very helpful to look at on a daily basis. Other Meditech functions. Section called linear dictation. There will be 2 linear dictations. You want to pick the one from 1102 forward. This is the most current documenting system that the physicians will use. You will only see one dictation if the patient has never been here before 2002. In this section, you can review their H&P and any consult notes. Things you might want to look for are evidence of a GI bleed, especially on the H&P. You want to look for those cues in their description of their chief complaint and in the A&P. You can also check these notes for any of the restrictive infectious diseases. Those can exclude conversion for linezolid and voriconazole. Remember, these are only for the antibiotics, not the automatic antibiotics. Another section in Meditech under PCI would be vital sign queries. You can evaluate temperature. When you select temperature and right arrow key in, it will give you all of the readings for the last 24 hours. Again, that is for antibiotics and not the automatic antibiotic categories. For laboratory, you go to hematology, right arrow key in. You can look at white cell count, right arrow key in again, and you'll see what the trend has been. You will be able to see, look back to the date, what the white cell count was on the date that the linezolid or voriconazole was started, and see if it's trending down. So that's a brief description of some of the Meditech functions and how to use PCI. If you have any questions about these, you should talk to your preceptor or the pharmacist that you're assigned to for IV to PO conversion. The next handout that we'll go over is called Student Responsibilities. On the first day of your rotation, you should check your Meditech email. You will find out which pharmacist you are assigned to. The pharmacists are set up in our schedule by letters, A, B, C. So if you were assigned to the B pharmacist, you will also be given a pager number to contact them. You will begin your IV to PO assignments on the second day of your rotation. It's important to note that you should do 6 to 8 IV to PO conversion assessments per day. In addition, you should do 3 to 4 food drug counselings per day. If you, for some reason, are not able to complete these assignments, it will impact the rotation grade, so you want to try to plan your day accordingly based on your rotation activities and your responsibilities with DCH. Now, once you have your pharmacist who you're reporting to, the letter and their phone, their pager number, you want to call them between 7 and 9 in the morning. They will give you a list to review from the Meditech work list, and then you want to report your findings back by 1 o'clock that day. This will give the pharmacist time to do all of the work that they need to do, especially for conversions and even to document failures. You want to take good notes for accurate reporting. A tip sheet or a note sheet has been developed by a former student, which is available in your student handout book. You can, if you find this helpful, you can make multiple copies of it and use it on a daily basis to try to track all of your patients. Like I said, it's not necessary to start over from scratch every day, so you want to, just like on your rotations, you want to get to know your patients and know what's happening to them on a daily basis. If the conversion is possible, you want to fill out the IV to PO form and give it to the pharmacist. When you go to report your findings to the pharmacist, it's good to bring your note sheet so you can go over the information with them. When you first get started, you may be a little uncomfortable making formal recommendations to the pharmacist. That's fine. Tell them what you found. Say, the patient's on scheduled oral meds, but they didn't take them this morning because they were nauseated. Let the pharmacist know that. Maybe we'll decide to wait a day and look at them tomorrow and see how they're doing. Anything that you're not sure about, if you saw some evidence of a GI bleed and you talk to the nurse, tell the pharmacist what you found. Let them help you make the decisions. And as you move throughout the month, you'll probably get more comfortable with making those recommendations. One last thing to keep in mind, I don't know if I mentioned, but the pharmacist, the letter you're assigned to, different pharmacists will rotate through those different, a letter is assigned to a particular staffing area in the hospital. So different pharmacists go through those areas. So you'll be interacting with different pharmacists. Make sure when you page them, you identify yourself as the student assigned for IV to PO to the B pharmacist. When you call them back or if you page them, make sure if you're putting in your cell phone number or if you're outside the hospital, make sure you put in all of the digits, including the area code, so that they can get in touch with you. If for some reason you are sick, you need to contact Tiffany Bolton at the number listed at the bottom of this handout so that your assignments can be given to another student. If you have a lot of activities going on in your rotation and you don't feel that you can get to it, it's okay to work a system out with another student to cover your work, but you need to let Tiffany know about that in advance. Just remember that that student may need you to also cover for them another day. So it's good to help each other out. We understand that things come up on your rotations, but we still need to make sure that we're covering all of our active patients. Now, we're going to go through the IV to PO quiz and the case studies. You should have worked through these, and I'll review the answers with them. When you come for your rotation, you'll want to bring your completed quizzes and case studies to turn them in. The first question on the quiz, switching from an IV to an oral fluoroquinolone is equally efficacious. C. The antibiotic conversion program will screen patients on linezolid or voriconazole for which of the following conversion criteria? Check all that are appropriate. A, we know we want an oral diet or scheduled oral meds. B, they need to have a decreased white cell count. D, they should not be NPO. F, patient has not had a temp spike greater than 102 in the past 24 hours. They should have received, G, they should have received IV antibiotics for at least 48 hours. And as I previously stated, they will not show up on the Midas report until they have had 48 hours of therapy. H, MD writes an order not to convert. And this is true for any of the categories, medications, antibiotics, and automatic antibiotics. If the physician writes an order not to convert, you need to tell your pharmacist that, and they will document it in Midas. And every day when that worksheet prints, it'll say, do not convert per MD. And we'll know not to continue to evaluate that patient during this admission. The final correct answer is J, diagnosis of osteomeningitis, septic arthritis, and endocarditis. The answers that we did not choose, the ones that are incorrect, are C, it does not depend on culture data. E, approval from Dr. White. Dr. White is an infectious disease physician, and we do not need approval from Dr. White, although he has weighed in on the criteria that we have for our program. I is also incorrect, diagnosis of pneumonia, UTI, or infectious pancreatitis. That was not in the restricted infectious diseases. The next question, explain all of the steps in the documentation process for a patient who fails to meet conversion criteria. Now, this is the same quiz that's used for our pharmacists. However, a lot of these things you will not be doing, so I'm going to explain them once and then we'll kind of skip over them for the students. If they fail to meet conversion criteria, I previously stated the pharmacist has multiple options to document failure reasons in Midas. So that's what they'll do, and that's coming from your assessment. So they're going to document these things. It'll print on the daily list, and we'll keep them there until those failure reasons no longer apply. When they don't have any failure reasons and they meet the criteria, we will convert them. And once they've been converted from IV to oral, they will no longer be on the Midas work list. The work list is triggered by the IV formulation of the drug. So if it's not present on the patient's profile, they won't show up on the work list. Now, if the patient met criteria and were converted, the pharmacist will DC the IV order and enter a new PO order in Meditech. They'll write an order in the chart, and they're going to use the IV to PO order form that you have filled out. The pharmacist will also document a clinical intervention. So you can see the only steps you have is in a failure, you need to report your findings for the failure reason the pharmacist will document. And if they meet conversion criteria, you'll want to report the reasons why to the pharmacist, and you'll want to prepare the IV to PO order form. The next question says, while evaluating a patient for IV Levaquin conversion, the pharmacist notes that they are tolerating their continuous tube feedings, then converts the patient to oral Levaquin via NG tube since they were tolerating an oral diet. Is this appropriate? Why or why not? No, this would not be an appropriate conversion. Tube feeds, which contain aluminum, calcium, and magnesium, will bind to the fluoroquinolones and then decrease the efficacy of our therapy. Number 6, a pharmacist refrains from converting a patient's Levaquin to PO because the patient's white cell count is 14,000, which is the same as it was on the day prior. Would elevated white cell count prevent conversion? No. The white cell count, the temperature, and the restrictive diseases only apply to the antibiotics, which include linezolid and voriconazole. For number 7, you want to complete the following conversions to the oral dosing schedules. You'll need to know this information when you fill out the IV to PO conversion form. Pepsid 20 milligrams IV Q12 hours will be converted to Pepsid 20 milligrams PO and from Q12 to BID. We have oral dosing regimens that are set. For the IV, those can be given around the clock. For oral doses, we want to make sure that they're given during normal awake hours. For Pepsid, 40 milligrams IV Q24, that will be 40 milligrams PO daily. Daily is our typical administration time, which occurs at 0900. All meds we generally try to get them at 0900 or 2100. That would be the BID schedule. If it's a once a day, you want to try to get it to as close to one of those two times as possible. Pantoprazole 40 milligrams IV Q24. This one would typically, you would think it would go to daily, but in this case it's 40 milligrams PO at 0630. Our PPIs are given prior to breakfast. Reglan 5 milligrams IV Q8 would go to Reglan 5 milligrams PO TID. Reglan 10 milligrams IV Q6 would go to Reglan 10 milligrams PO AC and ACHS. And lastly, Levaquin 750 milligrams IV at 11 o'clock daily. I told you previously we had two main times, 0900 or 2100. 11 o'clock is closer to 0900, so we would change this one to Levaquin PO daily at 0900. Case 1. RJ is a 69-year-old male admitted for a CHF exacerbation. He has started on a dobutamine drip, Lasix, and some oral meds, including K-Dur, Captopril. He also has IV Pepcid and IV Reglan. He has ordered a regular diet. Question 1, is there a target IV to PO medication in his list? Yes, Pepcid and Reglan. Would this patient meet criteria for conversion? Yes. He has both scheduled oral meds and an oral diet. Steps required to convert, we're going to skip those. We've already covered them. Most of them would be for the pharmacist. Case 2. DM is a 49-year-old male admitted for a female admitted for a total abdominal hysterectomy. Her post-op orders include IV fluids, morphine, cefotetan, Pepcid, but she is also kept in PO at this time, so no oral diet. Are there any target medications in the list? Yes, IV Pepcid. Would the patient meet conversion criteria? No, she does not have any scheduled oral meds and no oral diet. So steps required to document, pharmacists will document the failure reason. You would just communicate to them that there were no scheduled oral meds and no oral diet. The next section, the case numbers start over again. So we're at case 1 on CH, who is an 81-year-old female who was dehydrated, feverish, and confused. They were brought to the emergency room. Patient has a past medical history of a severe stroke which left her bedbound, and a history of anemia, thrombocytopenia, and psychosis. Vitals and labs are given. In the hospital course, she was admitted for a UTI, started on IV Levaquin, IV fluids, and home meds, which were continued, which included Lasix, multivitamin, and Pepcid. Patient was also prescribed an oral diet. On 12/17, the patient appeared on the IV to PO conversion work list. She has received 2 doses of IV antibiotics. White cell count is within normal limits, and temperature has not exceeded 99.2 degrees in the last 24 hours. So now you want to answer the following questions, criteria. Is the patient is receiving other oral medications or diet? The answer would be yes. They've had 48 hours of IV antibiotics. The answer would be yes. Question 2, is the patient eligible for conversion? Yes, because of the criteria we stated above. Now it says if you answered yes, describe the steps involved in converting the medication. So for the student, you want to get the IV to PO conversion form. You want to fill out Levaquin, and you want to put in a PO dose of 750 milligrams PO daily, beginning on 12/18. For this example, you are evaluating them on 12/10 at 10 a.m. The patient's dose was given at 0500. So on the 17th, they've already had their dose for that day, so you will begin on the following day, 12/18, at 0900. All of the other steps for documentation will be carried out by the pharmacist. Case 2, WH is a 75-year-old male admitted for cellulitis to the great toe. Past medical history labs are listed for you. An MRI shows extensive abnormality detected, which could be infectious etiology. It is suggestive of osteomyelitis. The patient was treated or admitted for the treatment of osteomyelitis. They were started on Levaquin and gentamicin. Home meds were continued, atenolol, Lasix, Elavil, and the patient was started on an oral diet. That was all done on 12/25. On 12/27, the patient appears on the IV to PO conversion list. They've been afebrile and white cell count is within normal limits. How do you answer the following criteria? Are they receiving oral medications and or diet? Yes. Have they been on IV antibiotics for at least 48 hours? Yes. Is the patient eligible for conversion? The question to this one may be a little tricky because osteomyelitis is one of the restrictive infectious diseases. However, that only applies to the automatic antibiotics, which are linezolid and voriconazole. And we're actually evaluating, for this patient, Levaquin. So in this case, yes, the Levaquin could be converted, even though it is one of the restrictive infectious diseases. It may not be the best therapy for this patient, but that's the example, and that's what they're receiving. If they had been on on linezolid or voriconazole, the answer to this conversion question would have been no. So at this time, you would fill out the IV to PO conversion form. You would do Levaquin, 750, PO daily, and they received it at 11 o'clock, and you're evaluating them at 11 o'clock, so it's a high likelihood that they would have their dose before you could make the conversion. So you want to start on 12/28 at 0900. Case 3. MC is an 80-year-old female. She was admitted for community-acquired pneumonia. Past medical history, vitals, and labs are present. Hospital course, on 12/31, she was started on Levaquin, Zosyn, and azithromycin, all IV. Home meds were held, and the patient was NPO. She appeared on the IV to PO list on 1/2 or January 2. White cell count is currently at 16.3, and temperatures over the past 24 hours are listed. You are evaluating the patient at 1300 on 1/2. Answer the following criteria. The patient is receiving other oral meds or a diet. The answer to that would be no. She is still NPO and no scheduled oral meds. Has the patient received 48 hours of IV therapy? Yes. Question 2, is the patient eligible for conversion? No. For the reasons that we answered above, no oral meds and no oral diet. So for number 3, you would tell the pharmacist the reasons for failure, and they would document them in Midas. On the following day, which is January 3rd, you would see them on your list again, and you're going to evaluate the patient. When you look at them again, white cell count is coming down, and temp has been below 102 for the past 24 hours. Even though those don't apply to, we're evaluating Levaquin and azithromycin. What we need to know is if the patient is on an oral diet, and that she has been. She was started on a regular diet and tolerating it well. They have also started some of her scheduled oral meds back. Is she eligible for conversion at this time? Yes. So for number 3, you would fill out the IV to PO conversion form. You would list Levaquin, 750 milligrams, PO daily at 0900. That is actually the time that she is receiving it. You also have to get azithromycin. These are spaced 2 hours apart because we don't know if the patient has a single lumen or a triple lumen catheter, so we have to assume that they can only receive one IV antibiotic at a time. So azithromycin would be 500 milligrams PO daily at 0900. All of these, let's see, you're evaluating them on January 3rd at 12 o'clock, so it's after the time that they received their dose for the 3rd, so these would both start on 1/4. You would give the form to the pharmacist, they would sign it, then they would complete all of the other documentation process, DCing the IV and entering the oral, and putting the order on the chart and entering the clinical intervention. Case 4, WH is a 75-year-old male admitted from a nursing home. Past medical history, he has problems with a swollen right knee. He has past medical history of rheumatoid arthritis, hypertension, coronary artery disease, depression, and anxiety. Labs are listed. For his hospital course, he was admitted for treatment of possible sepsis secondary to his knee infection. Antibiotic therapy was started on 5/5 with linezolid IV, and home meds were continued. He has scheduled oral meds, and an oral diet was ordered. On 5/17, they appear on the IV to PO conversion list. Patient has been afebrile, and white cell count is within normal limits. So now in question 1, you need to answer yes or no to the following questions. Is the patient receiving other oral meds and or diet? Yes. Has the patient received IV antibiotics for at least 48 hours? Yes. Now, we have additional criteria. Since this is linezolid, which is one of the antibiotic categories, we have to determine if the patient has a decreased white cell count if it was initially elevated, and the answer is yes. Has the patient has not had a temperature spike greater than 102 in the last 24 hours, the answer would be yes. The patient has not been diagnosed with osteomyelitis, septic arthritis, meningitis, or endocarditis. The answer here would be no. He was evaluated for possible treatment of sepsis. He came in with a knee infection, and we know that he has a history of rheumatoid arthritis. We have to assume that this is a possible case of septic arthritis. So is the patient eligible for conversion? No. Again, this is one of the restrictive infectious diseases that apply to the antibiotics, and he is on one, linezolid. So at this time, you would have the pharmacist document that failure reason in Midas of the restrictive infectious disease. On following days, or as long as he's here during this admission, we would not attempt to convert him anymore. So that completes the cases. As I stated before, when you come for rotation, you should be prepared to bring these quizzes and turn them in. You will receive a student handbook, and you'll notice that there is an intranet page. If you go to the DCH intranet, there's a pharmacy page, and there are some student resources on there. There's a refresher, a brief little refresher video on the IV to PO conversion program. Or you can also listen to this program again if you need to review, if it's going to be a while before you attend DCH for rotations, or if you come and have some time in between rotations and you need a refresher. As I stated before, this may be a little bit slow getting started, but make sure you talk to your preceptor and the pharmacist you're assigned to. Discuss any issues that you're concerned about and let them help you think through the process. Eventually, you'll get more confident in making recommendations on IV to PO conversion. If you have any additional questions, I would be happy to answer them for you. And please let us know if there's any issues that you can't get resolved within the program. So thank you very much for listening, and we really look forward to having you at DCH.